Hello everybody. This is the first lecture of the lower extremity. This lecture is going to cover the hip joint. So let's start with the functions of the pelvis and the hip. The pelvis is the stable base, and very important that we understand that because no movement can occur without a stable base. No distal movement at the legs without proximal stability, but it also supports the weight of the head, the arm, and the trunk. It contains and supports the viscera, the internal organs. The pelvis helps transmit and absorb superior and inferior forces. So not only the ground reaction forces from normal gait, but also anything that affects the upper extremities in the trunk. It provides a strictly controlled degree of mobility for both lower extremities. It's not quite as free moving as the shoulder joints we'll see here in a moment. Together, the pelvis and the hip help to produce the power necessary for closed chain activities. So this means walking for one thing. The main thing is walking. It also plays a role in elevating and lowering the body. The bones of the hip joint we can categorize again into two main components, the pelvis and the femur. The pelvis is really three fused bones together: the ilium, the ischium, and the pubis. Now, I've listed a few landmarks for each of the three bones. The ones that are italicized are the ones that you'll want to pay special attention to because you'll need these to measure goniometric movement of joints. So anytime throughout the lectures that you see italicized bony landmarks, just know that that is an important landmark, one that you'll have to be able to identify for goni. So the three main bones are the ilium, the ischium, and the pubis. The ilium has the ASIS, PSIS, and the iliac crest. Those are the ones we'll use for goni. The ASIS is the most prominent anterior landmark at the hip, and it stands for the anterior superior iliac spine. The ASIS is one that you'll very easily be able to use as a reference for movement of the pelvis. The ischium has the ischial tuberosity, and this is what most people refer to as the sit bone. That's a weight-bearing bone when we sit. The pubis has the symphysis. That joint is made by the cartilaginous disc that's found between the two, but none of these, of course, are going to be required for goniometric measurements. Those are in a rather personal space, so we'll try to stay away from them as often as possible. The right and the left innominate, or the os coxa, this is a collection of all three. When you talk about the ilium, the ischium, and the pubis together, you have a right and a left innominate. And then when we talk about them together, we have the pelvis. The three bones that make up one innominate fuse together and form the acetabulum, which is the socket where the hip joint is going to fit. The head of the femur fits into the acetabulum. There are a few more bony landmarks with the femur, but again, the italicized ones are the ones that you'll need to know for goni. However, all of these are going to be important because they are origins and insertions of muscles that move the hip or the knee joint. So the two that are highlighted here, the greater trochanter, this is that really bony prominence that's located on the proximal lateral aspect of the femur. It's probably the easiest one to palpate because it is such a prominent bone. And sometimes it's either this one or the ASIS. People are going to refer to as the hip bone. It just depends who you ask, but these two are commonly associated with the hip. The lateral epicondyle is at the very distal end of the femur, proximal to the patella, and it's a prominent landmark on the lateral aspect of the femur. And we'll talk about those more in lab. But again, this list is extremely important because you'll see these names come up as origins or insertions of muscles. The angle of inclination is the angle formed by the neck and the shaft of the femur. This angle is viewed in the frontal plane. This changes from infancy, but as early as age 2, the degrees the degree of the angle of inclination is about 125 degrees, and this is the same through adulthood. But this is an example of how our function necessitates our body's form or structure. Before any weight bearing occurs, so in babies, before any weight bearing occurs, the angle is actually about 150 degrees, a lot bigger. But as we start walking, which of course involves using muscles, and as you use muscles, you make them stronger, so you move more. As we start the process of locomotion, the force of gravity and the compressive forces on the hip from the muscles deepens the socket. And once that socket gets deeper, more of the head of the femur fits into it, and this lessens the angle to 125 degrees. And this is where it remains for the majority of adulthood. And we'll talk about this as we move through the lab. We'll be able to kind of get an idea of how this happens. Coxa valga is when you have an angle of inclination that is greater than 125 degrees. And coxa vara is when you have an angle of inclination that is less than 125 degrees. So what does having a bigger angle or a smaller angle do to you in terms of function? Well, let's start with coxa valga. If your angle is greater than 125 degrees, as in coxa valga, then you're more prone to hip instability. And again, if you just think back, this is the condition in infancy. You have a bigger angle than 125 degrees, coxa valga. And if you've ever held a baby, you know that they are anything but stable. So it makes a little sense when you think about it in those terms. But coxa valga is associated with greater hip instability even in adults. The functional increase of a leg, there's a functional increase of leg length. So this makes the legs seem longer because the pieces don't fit the same as they do on the other extremity. And again, we'll illustrate this in class. This can affect what you see at the knee joint. So this leads to a condition referred to as genu varum. And genu varum commonly is referred to as being bow-legged. So the knee angles out slightly with coxa valga. So coxa vara, again, where the degree of angle of inclination is less than 125, now you start to see more of a risk of femoral neck fractures due to tensile forces. So the position of the head of the femur in relationship to the neck of the femur puts that area at more stress and leads to more risk of fractures. There's also a leg length that can appear shorter than the other. Again, because of the way the bones are positioned, now the leg length seems shorter than if you had compared to the normal angle of inclination. And then finally, at the knee, you start to see what's called genu valgum, and this is the opposite of genu varum. Genu valgum is commonly referred to as being knock-kneed. So this is when the knees angle towards the midline, come in towards the body. Angle of torsion refers to the medial twisting of the femur, and this is seen best in the transverse plane. This happens as an embryo develops into a fetus. We've already briefly talked about this, but the legs rotate inward so that the body can assume the fetal position, and it's this rotation that leads to angle of torsion at the femur. The average angle of torsion is anywhere between 10 and 20 degrees. So this one's a little bit more difficult to picture. So we're going to use bones in the labs and in class to help illustrate this. Anteversion refers to an angle of torsion that is greater than 20 degrees, and retroversion less than 10 degrees. So what do you see as a difference with these two? With anteversion, you see an increase in hip internal rotation range of motion, and you also see a decrease in hip external rotation. At the knee, you see genu valgum, and at the feet, you actually see a toeing in because the femur being turned inward brings the entire foot with it, with the lower leg with it. Retroversion, again, the angle is less than 10 degrees. This is associated with an increase of hip external rotation range of motion. Genu varum at the knee, and a toeing out at the foot. Of the two, retroversion is by far the least common. So the hip joint is the articulation between the acetabulum of the pelvis and the femoral head. These two bones together give you the hip joint. And again, the acetabulum is simply the socket that is made by the three fused bones of the pelvis. The femoral head is the sphere that makes the socket of the joint, and both of these, when they articulate, are now enclosed in a joint capsule. In the pelvis, we have an anterior and a posterior tilt, and those are the ones that we're going to see the most often. This is a sagittal plane movement, and the easiest way to determine if somebody is moving into an anterior or a posterior tilt is to find the ASIS, the anterior superior iliac spine, and feel what happens as the patient moves the pelvis. If the ASISs are moving in an angled in a downward position, then that is an anterior tilt. When the ASISs angle up and are moved in the opposite direction, you're in a posterior tilt. The frontal plane movements are lateral tilts, and you can have a left or a right lateral tilt. You're simply using the iliac crest as a reference. If one is dipped down below the other, then that would be the direction of the tilt. The transverse plane, we can see protraction and retraction, and essentially what this is rotation of the pelvis. This is normal because this is a normal part of gait. It's called trunk disassociation. So as you're walking, your trunk is turning one direction and the pelvis rotates in the opposite direction. And this is referred to as protraction or retraction. Is an that's referred to as pelvic rotation. As an abnormality when a pelvis is turned more in one direction than another, then we refer to it as protraction or retraction. And you simply describe it by the side. All of these are going to have an influence on the position of the spine. But what I want you guys to think about right now is just take the anterior and the posterior tilt as an example. And I want you to think what an anterior or a posterior tilt will do to the movements of the spine. How does the posterior tilt or the anterior tilt affect the position of the spine? At the hip, what we have is a synovial joint. It's a ball and socket joint, which means that it is a triaxial joint. It allows 3 degrees of freedom. We have flexion and extension in the sagittal plane, abduction and adduction in the frontal plane, and internal and external rotation in the transverse plane. And these are all the motions that we can measure with a goni. I'm going to mention arthrokinematics in this lecture and probably not in any others that come along in this semester. But I do want you to have an idea of arthrokinematics because they are essential for normal osteokinematics. Arthrokinematics occur between the articulating surfaces and are necessary for normal movement. At the hip joint, we have these types of arthrokinematics that occur with movement, and we will discuss these in much greater detail in therapeutic exercise because it's impossible to do any effective joint mobilizations if you don't understand the arthrokinematics of joints. So I just want to introduce them now so that you are aware that they occur, and we'll hit them again in therapeutic exercise. So we've got the hip formed. We've talked about the bony segments that make the hip. Something's got to keep them together, and of course it's these ligaments. These 3 ligaments are very strong and are named by their attachment sites, so it makes it a lot easier to figure out where they are. All 3 work to primarily limit extension of the hip, and they're the main contributors to why we see such a difference in hip flexion range of motion versus hip extension range of motion. They also help us stand up with minimal muscle activity. These ligaments are so strong that the hip is mostly supported by these ligaments. Very little muscle is required to keep the hip stable because of these ligaments. So let's start with the iliofemoral ligament. This resembles an inverted Y, so it very often is referred to as the Y ligament. It runs from the ilium at about the AIIS, the anterior inferior iliac spine, to the femur at the intratrochanteric line. This particular ligament is located anteriorly and superiorly to the joint, so it helps limit adduction and external rotation. The second ligament we'll mention is the ischiofemoral ligament. This again also limits extension, and it runs from the ischial part of the acetabulum to the posterior femur at the neck near the greater trochanter. So this ligament is located on the posterior side of the hip, and in addition to limiting extension, it's also going to limit abduction and internal rotation. And then finally, the pubofemoral ligament. This ligament extends from the pubis to the anterior and inferior capsule near the neck of the femur posteriorly. This ligament runs anteriorly and inferiorly and helps limit extension, but also abduction and external rotation. Now the muscles here, there are many easier and more effective ways to learn these muscles than memorization, as we've mentioned before in class. So we're going to try everything so that you avoid doing that. I understand there's going to be some of that probably involved, but I would much prefer that we find other means to help learn these muscles. So we're going to organize these in class in several ways to help you see connections between location, action, and innervation. The more connections that you can make, the more sense that these muscles will make. So for right now, just to get you familiar with some of the hip muscles, I want you to take a look at this list. This list is organized by action. All the osteokinematics of the hip joint are represented here. The ones that are bolded or the muscles that are bolded indicate that they are the prime movers for that particular action. And it's extremely important that you understand which muscles are the prime movers and why they are considered the prime movers. So run through this list, get familiar with the names, and we're going to do a few activities in class to put all this together. We can worry about this in class. So there are some special considerations that are unique to the hip joint. And so we're going to cover a few of these here. The first thing that we'll talk about are the two joint muscles acting on the hip. There are two muscles that cover two joints that also affect the hip, and they're the rectus femoris, located on the front of the leg, and the hamstrings on the back side. Because of where their attachments are, they cross the hip joint and they also cross the knee joint. And two joint muscles are stronger when they only work across one joint, as we've learned, and don't have to work or contract across both joints. The hamstrings and the rectus femoris are also subject to passive insufficiency. So think about this for class. If you want to stretch the hamstrings across the knee joint, what would that patient's position look like? How would you achieve this goal? If you want to stretch the hamstrings across the knee joint, how would you do this? You have to use the principle of passive insufficiency to get to an answer, so I'm going to let you think about this. Write down your questions, have a response ready, and we're going to discuss this in class. Eccentric versus concentric contractions. This is most important when we're talking about movement during weight bearing. Again, your hip has to support, the hip and the pelvis has to support about 2/3 of your body weight. Everything from the pelvis up, your head, your arms, and your trunk. This means that the lower extremity muscles play an important role in moving all this weight, and they have to do it in a smooth, controlled motion. So a lot of movement involves decelerating the body. And it's when we decelerate the body that muscles start to work eccentrically. And very important for functional activities. So we're going to go through some of these in class and start to parse out what makes something eccentric in functional terms and what makes something concentric. The abductors are extremely important muscles for weight bearing and for gait. Primarily the gluteus medius is a muscle that helps support the pelvis during gait. If you have a glute medius that is unable to support the pelvis, then every step you would take, you would have a drop in your pelvis. If you've ever seen runway models walk where they have that stride that leans one hip to one side, so you always see the hips shifting one direction to the other as they walk, that would be what a person with a weak gluteus medius would walk like. Every step they take, the pelvis would drop, and as they take the next step, the other side would drop again. So the glute medius is very important for gait because it helps stabilize the pelvis. It adds to that proximal stability so that we can have that normal distal mobility. Now the inguinal ligament is pretty much the separation of the abdomen from the thigh. So this is where we can draw the line between the trunk and the lower extremity. It runs between the ilium and the pubis, and it is made from the aponeurosis of the abdominal muscles. The aponeurosis is a layer of flat, broad tendons, and what they do is they function to join muscles and the body parts that they act on. This is a term that you're going to see throughout the semester, so just kind of get used to seeing it, and we'll run through some of the illustrations in your atlas about an aponeurosis. Next, let's talk about the femoral triangle. The femoral triangle is the region, again, we're talking about the junction between the leg and the trunk. The boundaries of the triangle, since we are talking about a shape here, let's give them some boundaries. Superiorly is the inguinal ligament. Medially is the adductor longus, and laterally it's the sartorius. When these three structures meet, we get a border of a triangle. And the reason that we talk about this is because of what is found in the triangle. We have the femoral vein, the femoral artery, and the femoral nerve. And it's always described medial to lateral to help you remember what order they run in. So if you think vein, artery, nerve, medial is vein, in the middle is the artery, and the most lateral is the nerve. And that's the way they're positioned in this triangle. So very important structures. So why do we care about this area? Well, obviously these structures don't really do well when there's lots of compression on them. So we need to be careful not to press too much over the region because of these three structures. This is also a site for easy access to a major artery, the femoral artery. It provides direct access to the heart. So lots of procedures that involve the heart, angioplasties, and several others start at the femoral artery and use that as a highway, if you will, into the heart. And then finally, the last thing we'll mention are the bursa. These are found sometimes through synovial joints, but they are found mostly in areas where there's soft tissue next to bony landmarks, big prominent bony formations. So the bursa is there to help decrease friction between soft tissue and a bone, or to help decrease the compressive forces between soft tissue and a bone. Typically, it's going to be soft tissue and bone, but you sometimes may find them between soft tissue and soft tissue. Found over the musculotendinous regions or between muscles and bones. The ones at the hip, you'll see them at the greater trochanter. Again, that's a very big, prominent bony bony landmarks. So we have a bursa there to help minimize the friction and compression between the trochanter and the IT band or the TFL, any of the muscles that are in that area. We have the iliopsoas and the pectineal region. The iliopectineal bursa helps minimize friction and compressive forces here. And then finally the ischiogluteal bursa. We talked about the sit bone. It's a pretty prominent bony landmark, very easy to palpate. So the ischial tube has got a bursa so that it helps minimize the friction and compression forces between that and some of the muscles in the area. All right, so this is the end of the hip joint lecture. Again, read the textbook, cover the pages that were in the reading schedule to hopefully help clear up some of the questions you may have. Make sure that you've jotted down some of your answers to the questions I posed, and that you bring your questions with you to class. All right, see y'all in class.